Good afternoon, everyone, and welcome to the third webinar in our JCOIN speaker series, Reentry Research, Mitigating Risk During Reentry for People with Substance Use Disorders. My name is Jessica Holsey with Addiction Policy Forum. We're part of the Coordination and Translation Center within JCOIN, and so excited to work with you all today and have so many join us from all over the country for this important topic. We have really great speakers and a great lineup for you today to discuss reentry, including Dr. Carrie Oser from University of Kentucky, Dr. Tyler Winkelman from Hennepin Healthcare Research Institute, Dr. Faye Taxman from George Mason University, and of course our very own Dr. Tisha Wiley, who is the branch chief at National Institute on Drug Abuse, NIDA, which is within NIH, the National Institutes of Health. The JCOIN speaker series aims to connect you all, practitioners and those in the field, with the latest research and scientists who can weigh in on topics that you have raised as areas of concern and interest. So we're very excited to be able to dig in today. I think we wanted to start off by having Dr. Wiley give us a bit of a background on JCOIN and sort of kick us off on this topic.
Great, thank you, Jessica, welcome everyone. We're really glad to be with you today and glad to share with you some insights from the work that NIDA has supported over the years on reentry work. One of the things that's really exciting is that in 2018, Congress appropriated $500 million a year to the NIH to help address the opioid overdose crisis. That turned into the Helping to End Addiction Long-Term, or HEAL initiative. So when you hear us reference HEAL, that's what that stands for. And the HEAL initiative cuts across all of the NIH. Half of the funds that were appropriated were dedicated to addressing pain and the other half to addiction. And through those addiction funds, we had the opportunity to stand up the Justice Community Opioid Innovation Network, or JCOIN. And that's what allowed us to fund one of our biggest investments in justice research historically. And we are really excited because our overall mission through JCOIN is to work together to ensure that every individual who is involved in the justice system that has a substance use disorder has access to effective treatment, and that's something that we're working toward, whether those folks are detained or they're in the community. Through JCOIN, we were able to fund many different projects. We have more than 50 different research projects now that are going on. But importantly, we also were able to support a lot of infrastructure to help us try to make sure that we translate those findings back to practice. And we're working to develop a network of researchers who are collaborating really closely with practitioners across both justice and community settings in order to do that. And through those efforts, we hope to build capacity and become a go-to resource. And ultimately, all of those things together, we hope will help speed the translation of science to real-world solutions that can be applied really broadly. And this seminar series is part of that effort. I really want to thank Addiction Policy Forum and Jessica Holsey and the rest of her team for pulling this all together and to connecting us to all of you so that we can share these findings. We know that addressing reentry is really critical. Research has shown us that the first few weeks that someone returns to the community from a secure setting is one of the highest risk periods for overdose and overdose mortality. And there's a lot we can do to prevent that. And several of our studies in JCOIN are testing lots of different models about how to do a better job of facilitating that transition between jails and prison and back to the community. But while we're expanding that evidence base, we're also building on decades of work that have shown over and over that contact with the justice system can present an opportunity to connect people to evidence-based care for their opioid use disorder. And that means buprenorphine, methadone, and naltrexone as some of our primary tools that we have in our toolbox to support that. And our shared goal is to help people transition people back to the community and get them connected in ways that support their recovery and help them contribute to society in positive ways. And beyond any one individual, that means moving the standard of practice so that people who have OUD are routinely returning to the community connected to care And that's something that can simultaneously protect both public health and public safety. So I'm going to move out of the way because we've got some really great researchers today to share with you some of their research. Dr. Winkelman is going to talk about what data tells us about how medications can reduce mortality and criminal activity, and lots of the research that has been that we have already about all of that work. Dr. Oser is going to talk about another HEAL project, the Healing Communities Study, and the efforts within that study to focus on harm reduction. The Healing Communities Study is not part of JCOIN, but it is another very large initiative within HEAL. And that effort really focuses on approaching communities holistically, and jails are a critical part of that community-wide strategy. And finally, Dr. Faye Taxman, who leads our Coordination and Translation Center, is going to talk about some of the broader issues around reentry and identity transformation and all the things that tie that all together. So I really want to thank you for joining us, and I hope you're going to find this information useful. I also want to remind you that we have a lot of other resources within JCOIN. Those resources are constantly evolving. So please share any questions you might have or requests you might have with us about how we can support the translation of our research findings out to practice and meet the needs that you might have. And thank you again for joining us. I'm going to turn it back over to Jess.
All right. Thank you, Tisha. Dr. Winkelman, can I hand it over to you?
Absolutely. Let me share my screen here. Can I get a thumbs up? Does it look all right? Great. All right. Well, thanks, everyone. It's such a pleasure to be here with you today and to talk about a topic that's near and dear to my heart. So I'm Tyler Winkelman. I'm at Hennepin Healthcare in Minneapolis. I'm a primary care doctor at Hennepin Healthcare, which is the safety net health system here. I practice clinically in the Hennepin County Jail and some of our primary care clinics and do research primarily on issues at the intersection of healthcare and the criminal justice system. So I'm going to just talk a little bit about what we do and do not know about medications for opioid use disorder in criminal justice settings and what that means for reentry. And then I'll spend a little bit of time talking about barriers and facilitators to MOUD continuation on release. So first, I'm sure most of you on the call know this already. Tisha touched on this information already, but I think it's just critical to understand. So our group has done some work looking at the overlap of opioid use and criminal justice involvement. And what you can see is that among people who report prescription opioid misuse, about a third will come into contact with the criminal justice system. Over 50% of people with an opioid use disorder will come in contact with the criminal justice system. And over 3/4 of people who report using heroin will come into contact with the criminal justice system. So the overlap of people with opioid use disorders and criminal justice involvement is extremely high. And many of you, I'm sure, are aware of this seminal study by Ingrid Binswanger and colleagues looking at the risk of death after release from prison in Washington State. And what they found is this extraordinarily high rate of death in the 2 weeks after release from prison. That risk goes down somewhat, but stays above the predicted values up to several months after release. And most of these overdose deaths are driven by, overdose. And so what this means is that if we are going to address the substance use crisis that we're in, there's almost no way to fully address the problem without thinking about the role that healthcare in the criminal justice system plays and how reentry impacts the success of programs for people with opioid use disorder. So what do we know today about treating people with opioid use disorder in criminal justice settings. We know a bit, and I'll before I show you the data, maybe I'll just jump to the punchline, which is that reentry really starts while someone's incarcerated, and the evidence is clear that providing medications for opioid use disorder is essential to reentry and should be started while people are incarcerated. So this study comes out of Australia, and they looked at people with heroin use disorders who were leaving prison, and they looked at people who continued medication, methadone, in the month after release, and those who were not maintained in treatment. And what they found is about a 4-fold increase in age-adjusted death after people left prison. So when people stay in treatment after they leave prison, it can potentially be a life-saving intervention. Jody Rich and colleagues looked at another policy of continuing individuals on methadone while they're incarcerated. This is in the United States versus forced withdrawal. And what they found was much higher rates of treatment reentry after release. So again, driving home this point that what happens in jails and prisons is essential to what happens after people leave jail and prison. Another study, again, in the United States, on the East Coast, randomized groups in prison to 3 different interventions: counseling only, counseling plus a transfer to a methadone clinic after release, or counseling plus initiating methadone while someone was incarcerated. And what this study found was that individuals who were continued on methadone or started on methadone while they were incarcerated were more likely to be retained in treatment, had less heroin use, and had less criminal activity. And these results held even a year later. So when you look at these different groups, counseling versus counseling plus a transfer to a clinic versus counseling plus initiating treatment while incarcerated, the group who initiated medication while incarcerated had a much longer duration of treatment following release. So one of the key findings here is that starting medication while incarcerated seems to be superior to not starting it while incarcerated and then referring out on release. Again, reentry starts while they're incarcerated. Others have looked at buprenorphine versus methadone, and really there doesn't seem to be a big difference after release between the 2 medications. There's also been a study that's looked at buprenorphine during incarceration versus counseling alone. And the group that received buprenorphine was much more likely to enter community treatment after release compared to people who received counseling alone. So again, getting medications while incarcerated, a very, very important piece of ensuring a successful reentry. And then there's also another study looking at naltrexone versus counseling. And at 24 weeks after release, there was a lower relapse rate in the naltrexone group, long-acting naltrexone versus counseling. At 1 year, there was no difference between the groups. This is a study not from the criminal justice, from a criminal justice setting, but I think has some relevance to decisions that practitioners have to make. So this is a commercially insured population. What they looked at is among patients who were on buprenorphine during their periods of active buprenorphine prescriptions, did they have lower rates of overdose than periods of time where they had an inactive buprenorphine prescription? And what they found was a dramatic decrease in overdoses among people during periods of time when they had an active buprenorphine prescription. Conversely, they looked at individuals who were prescribed extended release naltrexone and did not find a statistically significant difference in overdoses in this group between periods of time when they were receiving the naltrexone and periods of time when they weren't. So what does the evidence to date tell us about ensuring a successful reentry for people with opioid use disorder? So number one is that forced withdrawal reduces treatment entry after release. Starting medication during incarceration is superior to community referral or counseling. Results generally seem to be similar for buprenorphine and methadone. And there's evidence that naltrexone is effective compared to placebo, but it may not be cost effective or reduce overdoses relative to buprenorphine. And these data are outlined now in a number of guidelines that are from a variety of organizations, including SAMHSA, NCCHC and the National Sheriff's Association, and work by the National Council for Behavioral Health. And all of these are available online and really wonderful resources. And I think the National Academy report probably states the summation of these findings most succinctly in their report titled Medications for Opioid Use Disorder Saves Lives. And one of the key conclusions of this report is that medication-based treatment is effective across all treatment settings. That's including criminal justice settings. That's the data I just showed you, and withholding or failing to have available all U.S. Food and Drug Administration approved classes of medications for the treatment of opioid use disorder in any care or criminal justice setting is denying appropriate medical treatment. So these medications really are first line therapy now, and they are the FDA approved evidence-based way to treat opioid use disorder. They're effective in criminal justice settings, and they're essential to a successful reentry. So we know that reentry or that medications for opioid use disorder are effective. What is less clear is how do we drive up those treatment retention rates once someone is in the community. So we know if you start medications while incarcerated, your treatment retention is going to be higher than if you didn't start medications, but how can we really optimize the retention in treatment? And one of the approaches that many people are interested in is through collaboration with peer recovery specialists or community health workers. This is the focus of a number of studies in JCOIN. So at Hennepin Healthcare, we're part of the hub that is headquartered out of Yale, and we are examining whether the transitions clinic model, which relies on or is centered around the work of a community health worker with a history of incarceration, can help people stay in treatment after release from jail. And so just a little bit about the Transitions Clinic Network as an example of one of the studies that's underway through JCOIN, and also has some similarities to a number of other studies really focused on how can peers and CHWs help with treatment retention after release. So the Transitions Clinic Network has really three main goals: a programmatic goal, a research goal, and a policy goal. And what I'll be talking about primarily here are the programmatic and research goals. The TCN is implementing this evidence-based specialized program within community health systems across the entire country. 5 of these sites are involved, or 6 of the sites are involved in the JCOIN study. And this research component obviously links to the work with JCOIN, but follows a long history of research looking at the impacts of these programs. This particular model relies on an enhanced primary care model that is the center of the model. It is flexible and can interact with a variety of community-based supports. The model really centers, again, around this individual, a community health worker with formal training who has a history of incarceration, who brings their lived experience both to the team and to the patients that they serve, who's been in the patient's shoes and can really understand the complexities of navigation that the patient is having to deal with after release. The model also includes mental health care, substance use treatment, and a very broad spectrum of primary care, including hepatitis C treatment, and this care is trauma informed. The role of the community health worker, like many roles of other peers, peer recovery specialists and so forth, is quite broad. And the goal is sort of twofold. One is outreach and meeting patients where they're at. They may meet patients at their discretion at parole office, in their homes. If they're reincarcerated, they'll meet them in jail or prison. If they're hospitalized, if they're unhoused, they will meet with the patient and understand what the individual needs of that particular patient are. And then the second piece is really focused on health system navigation and helping individuals enroll in medical assistance, in helping with their medication, in getting their appointments, and so forth. And this is all centered around that lived experience and being able to connect with patients in a very personal but professional manner, and being able to both share their professional understanding of the resources that are available, while also bringing that empathy that comes from having similar lived experience. I'm going to skip these for now, but I will say that there's been some preliminary evaluations of the TCN, and it can help reduce emergency department visits and has been shown to help people stay in care. What we're studying is, does this model also apply to treatment of opioid use disorder and retention and care? Just a couple other important pieces to keep in mind when thinking about reentry for people with opioid use disorder. The first is the Medicaid inmate exclusion. So this is a federal law that bars states from receiving federal matching funds for care provided to individuals in jail or prison. So this policy, it reduces the ability of correctional facilities to respond to public health crises, because they have finite budgets that don't change and don't have the ability to flex like the Medicaid program can. The other piece of this is that Medicaid insurance is often terminated or suspended once someone is incarcerated. And so if someone started on medications, it may be that their insurance is shut off while they're incarcerated. And this can make reentry extremely complicated and is a critical issue to address on release. We've done some work in Hennepin County looking at the impact of these types of policies. What we find in our expansion population is that about 30% of individuals who have Medicaid through the Medicaid expansion had some type of criminal justice involvement in the last 5 years. But when you look at the folks who have substance use disorder, mental illness, it's about 60% of people. So this particular policy really impacts a large proportion of individuals with substance use disorder. The second is that there are very few jails and prisons that have electronic medical records that communicate with community sites. And so accessing records can be logistically challenging and expensive. Our team called the Department of Corrections in each of the 50 states to understand what obtaining health records in a given state look like. And there are some states where patients actually are not allowed to access their medical records. There are other states where a 50-page medical record can cost a patient up to $100. So this is another issue to be aware of, that trying to understand the treatment that was received in jails and prisons can be challenging and expensive, and ensuring that there's a smooth transfer of information to a community provider is very important in ensuring that treatment can continue in the community. And then the last point that I want to make is around polysubstance use. So we've done a number of projects looking at polysubstance use for people with OUD, and most individuals who have an opioid use disorder will be using other substances. In particular, recently, co-use of opioids and stimulants like cocaine or methamphetamine have increased dramatically. But importantly, other substance use is not a contraindication to starting medications for opioid use disorder. So when you are thinking about starting people on medications during incarceration and continuing that medication on release, co-occurring substance use disorders are not a contraindication to starting MOUD. A reminder that there are lots of substance use disorders that are common among individuals in the criminal justice system. And so there are medications available for some of these substance use disorders, like alcohol use disorder. And then, as I mentioned, stimulants are an increasingly common substance among folks in the criminal justice system. At our jail, stimulant use disorders are probably twice as common right now as compared to opioid use disorders. Unfortunately, treatment options for stimulant use disorders are more limited, and certainly something that I'm sure many of you have been seeing more of in the last several years. So just to conclude my remarks before I hand it over to Dr. Oser, OUD is common among criminal justice populations, and reentry for opioid use disorder and other SUDs starts on admission. Community health worker and peer navigator-based models are very promising approaches to engage individuals in care, but they do require additional evaluation, and this is what JCOIN in part will be investigating. And then Medicaid enrollment, transfer of health data, and polysubstance use are important considerations upon reentry. With that, here's my contact information. If anyone would like to reach out afterwards, look forward to the Q&A, and I will hand it over to Dr. Oser.
Thank you so much. Can you all see my screen? Can I get a thumbs up as well? Thank you. My name is Carrie Oser, and I'm a professor at the University of Kentucky. I'm trained as a health criminologist, and I'm fortunate to be at UK, where we are part of two of the largest initiatives under that HEAL umbrella, both JCOIN and the Healing Community Study. So what I'm going to be talking about today is one harm reduction approach at reentry that's very important for saving lives, and that's overdose education and distributing naloxone to people at reentry. And I'm going to share some examples from both our JCOIN study as well as the Healing Community Study. So this is a brief outline of my talk today. And I want to end with some lessons learned and talk about sustainability as well, because I think it's very important when we introduce these evidence-based practices into a justice setting. We need to make sure that we have plans to make sure that it can continue beyond the scope of the research study. So let's first begin by talking about the importance of naloxone during reentry. And Dr. Winkelman did a great job because he set the stage for me talking about why this is so important, because there's an elevated risk of overdose deaths during that reentry period. We have several studies that have supported this. And the reason that there's an elevated risk is because when people are incarcerated, tolerance is reduced. And when they're returning back to the community, if they return to their previous use levels, then their tolerance is diminished and they're at risk for an overdose event. So we all were really surprised, I think, when we got hit with COVID-19, and it's really changed the substance use landscape. People who are in jails and in prisons, and also people who have substance use disorders are at heightened risk of COVID-19. And so what happened was there was an early release of nonviolent offenders in a variety of states, and there was also increases in the number of people who were on community supervision. But the landscape changed a bit because most people were not reporting in person, and there was also limited urine drug screening. In terms of the behavioral health care landscape, there was reduced access to inpatient residential treatment and reduced social service access overall. There were concerns about overdoses, and I know in Kentucky, we saw a spike in May in terms of overdose events, the highest that our state has ever experienced. It's kind of leveled off a bit, but these overdoses are presenting challenges in terms of straining our already overstrained healthcare system and our emergency response systems, because they were dealing with the COVID-19 pandemic. So how do we reduce opioid overdose deaths? Well, we have a lot of things in our toolkit. And one of those things was discussed earlier, and that's medications for opioid use disorder, which are an evidence-based practice to reduce overdose deaths. But we also have something else in our toolkit, and that's naloxone. We can save a life with a simple spray. And so through our studies, we have tried to integrate overdose education and naloxone distribution to people who are being released from jails, and also to people who are on community supervision, including those who have been newly released. So what is naloxone? It is a medication that's used to respond to an opioid overdose event. It has no abuse potential. There's no interactions with other medications, and it doesn't cause any harm if used by mistake. So it is a generally safe medication. I think there's a lot of stigma that still surrounds naloxone, and I'm happy to talk about that further. But people who are involved in the justice system have not had adequate overdose education. A recent study found that only 3% of people in jail had ever received overdose education in the community. And in this study of over 650 people, they distributed naloxone at reentry, and 1 in 3 people reported using the naloxone to reverse an overdose. 1 in 3. That is a really high percentage of use. So these are people who are being released to drug-using networks. Our communities with enrollment in overdose education and naloxone distribution programs overall have lower rates of overdose deaths. So it's important to focus on jails and reentry because they are part of our communities. So within JCOIN, we have a study that's focused on an intervention trial with women who are incarcerated in jails. And when the COVID-19 pandemic hit, we decided that we wanted to integrate OEND into our research protocol. So we're embedding this into a research study that is ongoing within 9 different jails. And we have, through the JCOIN network, partnered with the Healing Community Study to use a overdose education video that's about 9 minutes long that was created to inform people about how to recognize the signs of an overdose and how to appropriately respond during the COVID-19 pandemic. So that was the innovation of this brief education video. So in our JCOIN project, after data is collected inside the jail, the video is shown to the individual by research staff, and the research staff places the naloxone units into a basic project hygiene bag, which has an educational brochure that's available in both Spanish and English, and puts that into the person's personal property in the booking center, so they receive it when they're released. And also replacement naloxone units are offered at follow-up data collection appointments. I think the challenge with this sort of study is the sustainability, but it is one model and it can help save lives if we embed this, or at least share information with participants about how to access naloxone upon release. So I want to share a little bit more about the Healing Community Study, which again, this is a sister study of JCOIN. And the Healing Community Study is a community engaged implementation science study, the largest that NIH has supported. And what we're trying to do is to test the impact of an integrated set of evidence-based practices to reduce opioid overdose deaths. There are 4 different sites that have received Healing Community Studies awards, one in Kentucky, Massachusetts, New York, and Ohio. And this project is a really grassroots driven by our local communities. And we have collaborative support at the state level and wonderful federal partners through NIDA and SAMHSA. And then also within our communities, we're working with a variety of sectors, including behavioral health, criminal justice, public health, and healthcare partners. In this study, what we're doing, we have selected highly impacted communities by overdoses. So they have overdose death rates that are above the national average, and a data-driven approach was used to select these communities. There are 67 across the 4 states and 16 specifically in Kentucky. It's a randomized trial, a waitlist controlled trial. So half of those communities are starting the communities that heal intervention first, and then the other half of the communities have a delayed start date. So the overall goal of the aim of the Healing Community Study is to test the impact of the communities that heal intervention on opioid related overdose deaths. So what does that mean? Well, what we're currently doing is we're working with coalitions, community coalitions, to develop a data-driven community response plan. So we know what works in terms of evidence-based practices for reducing overdose deaths, but the challenge is integrating those evidence-based practices into agencies to have a real-world impact. And so our community partners know their communities the best, and these coalitions have selected which evidence-based practices should be deployed in which agencies. And through partnerships, we're working with agencies in a variety of different sectors, including the justice sector, to try to implement those evidence-based practices to reduce overdose deaths. So the Communities That Heal intervention has 3 major components. The first is that community engagement component, where coalitions are working through a 6-phase process to develop that response plan that's specific to their community. The coalitions have a menu of evidence-based practices to select from, and that is called the Overdose Response Continuum of Care approach. And essentially that's comprised of 3 different sets of evidence-based practices. And that's different ways to implement naloxone distribution, scaling up access to medications for the treatment of opioid use disorder, and also improving prescribing practices. So, our coalitions have selected these interventions. We're working with agencies to implement them, but stigma still exists. And so the third part of the Communities That Heal intervention is a public health communication campaign that features people from these local communities who are providing testimonials and sharing their stories on billboards, through social media, and through a variety of different outlets to help decrease stigma and drive demand. So, in one of our counties, we have the police chief who's featured on one of these, and the recognizable figureheads, as well as real people with lived experience from those communities. So when COVID-19 hit, we met as a consortium across the 4 different states and decided that we wanted to focus on how we could get OEND out into our communities as quickly as possible, because I mentioned before, our healthcare system and our emergency response systems were strained by COVID, and we didn't want to see a spike in overdose deaths. And so in Kentucky, we decided to focus on our jails first, because the jails were having releases of people who were incarcerated. And we have a standing order agreement through the Healing Community Study, which means that one of our physicians on our team essentially can prescribe a prescription to an agency who can then dispense naloxone. We can then dispense naloxone to the agency, and the agency can distribute the naloxone to people who have been trained in overdose education. And it's not an individual prescription to a person where their name is on the naloxone unit. It's a standing order agreement with an agency. In our Healing Community Study Naloxone program, we thought that we could create a very simple kind of model that we would approach jails, and we would share information about the standing order agreement. Our study would dispense the naloxone to the jails. The jails would be responsible for the overdose education and tracking the distribution of the naloxone. That worked in some jails, but some jails we needed to be a little bit more flexible and innovative. And so what I want to do next is to talk about some resources that we created to help our jails with providing overdose education and naloxone distribution. We created some pamphlets that were specific to the study in both Spanish and English that could be distributed with the naloxone units. And we also created that overdose education video that's being used in our JCOIN hub as well, that addresses how to respond to an overdose event during COVID. And we have a variety of flyers and palm cards and different materials that are available to provide additional educational opportunities for people. So we have 3 required components through that standing order agreement. First, it's required that there's overdose education training, and the training can be delivered in a variety of different formats. There is some brief data collection because it is a research study. By brief, I mean just a few questions. And we have to track the distribution of the naloxone units in terms of the numbers of units that are distributed. I'm sorry, I have a little dog. And so there are a variety of successful models that we've pursued with our Healing Community Study. We're currently working with 8 jails in our Wave 1 communities, and jails can choose more than one implementation strategy, and sometimes jails have to adapt their strategy, and we have implementation facilitators who help identify ways that we can make a more effective and have a better reach to the population. So I'm going to talk about 4 different implementation models here in a little bit more in depth. The first model is an online course delivery. And 4 of the 8 jails in our Wave 1 community all had the same corrections communication company called GTL. And so we have partnered with GTL, who connected us with another company called CipherWorks, which is an adult learning management platform. And when we partnered with CipherWorks, we have created essentially an online opioid overdose education module that then GTL has placed on tablets inside the jail that are accessible to everybody who is incarcerated. Some of our jails, each person has their own tablets. And then in some of our jails, there are tablets that are shared in the dorm. And these tablets are used to communicate with people who are not incarcerated, to do commissary orders, and also for these educational opportunities. So CipherWorks can track who completes the opioid overdose education course, which is essentially watching the video. And then They send weekly lists to jail staff about who has completed the overdose course. And jail staff can also access the software program directly to see who's completed it. And the jail staff is responsible for distributing the naloxone prior to release at either the booking center or one of the jails has individuals see a nurse prior to release for the naloxone distribution. The second implementation model is sustainable because our jail staff that we're partnering with are using that brief brochure to provide in-person overdose education to people who are incarcerated. And it's occurring in different formats. One of the jails is bringing people together like during lunchtime, and they have group education trainings. There's also been a transition in that jail to a nurse education model at both entry and prior to release. And then in another of our jails, the jail staff looks up who's nearing release and goes to their specific unit and provides the overdose education in a one-on-one basis to individuals. And again, the jail staff is distributing the naloxone to people who receive that education component. A third way that jails are providing OEND is through interagency partnerships. So this has really been a great opportunity to leverage our coalition members and also other community-based agencies that we're partnering with through the Healing Community Study. And in this scenario, the other agencies are coming to the jail to provide overdose education and distribute the naloxone. One of our jails, and this has actually been a very successful model, a jail is just a few doors down from a recovery community organization. And whenever someone's being released, the jail calls the recovery community organization. A person goes down to the jail, provides the overdose education, and distributes the naloxone in person. And then we've also partnered in one of our jails with a syringe service program for use of their mobile unit to come to the jail. And the mobile unit has been able to provide OEND to people at release and also to their family and friends who may be picking them up. This model has actually not worked as well, but it's because of the layout of the jail and the mobile units not able to be placed close enough to be able to access people. And so we're working with that jail on a different implementation strategy. And then we also have a passive approach in one of our jails where right now they're providing flyers to people in their personal effects to let them know where they can go get overdose education and free Narcan at their release. And then finally, we also have an in-person education implementation model where a peer support specialist is placed inside the jail, and the peer support specialist has access to the jail tracker, to the jail management system, so they can look up when people are being released, and they have access to move about the facility and provide in-person overdose education, and then place the naloxone in the person's property. And so you can see how some of these models also lend themselves to linkage to medication treatment for people who have opioid use disorder at community release, and especially this peer support model lends itself well to that model. So in addition to our jails, we've been working with the Kentucky Department of Corrections to provide OEND to people who are on community supervision. And we've used one model there where we have created a website that has the overdose education video, and the person watches the brief 9-minute video and answers a few knowledge questions to make sure they understood the video, and then enters their address through a separate platform, and naloxone is shipped to their home address. And we've used a variety of different strategies to drive people to this OEND website. So right now, there's about 20% of people who are reporting in person in Kentucky, and that's starting to scale up because of increased vaccinations for COVID. But we started by some strategies for those people who were reporting in person. And we purchased and installed TVs in all of our PNP offices. And on the TVs, we have created a programming loop. So the programming loop includes the overdose education video. It includes a video about medications for opioid use disorder. And then it includes some of the health communication campaign materials that we developed as part of the study. And these are on a loop shown in the probation and parole offices. Accompanying those, there are posters that are in the waiting rooms, as you can see one right here, that have post-it pull tabs that have a QR code in the website that tell people where they can access the video and the free naloxone distribution. And our probation and parole officers are handing out kind of little index size cards with this information as well. We also worked with the Department of Corrections to be able to provide this opportunity to everyone who's on supervision. And so probation and parole could not share personal information, so they could not give us people's addresses. But what we agreed upon was that we drafted a letter that includes a testimonial from a person who has lived experience and who has saved a life by administering naloxone and has been involved in the justice system. And on that letter is the testimonial and then information about how to go to the website, either the QR code or the website address to do the education video, watch the education video and enter their address. And we've been able to ship out about 75 to 8,000 letters several times over the course of the study. And we would provide the letters stamped, sealed, and addressed to the probation office. And the probation office would print the individual's address label and put it on the letter and mail it out. We've also been able to leverage the texting system that the officers are using and have been relying on heavily during COVID. And anybody who has a registered cell phone who's on community supervision receives a text that directs them to the website. And then finally, we've been really pleased to be able to partner with DOC. They're implementing a new statewide probation and parole reporting app. And we've been able to integrate the link to the website on the reporting app. So you can see right here on this first screen what the person who is on supervision sees, and the red bar says tap for free Narcan and overdose training, and individuals who are in our Wave 1 communities can click on that link through the app, which directs them to the website to watch the video and enter their address for naloxone distribution. So overall, we have figured out that there is no one size that fits all of our criminal justice agencies, and our partners have been really wonderful in sharing ideas about how we can increase our reach to justice-involved populations. If you've been in one jail, you have been in one jail, because each correctional agency is very different. We've learned to listen to try to understand what resources are available and what are the competing demands. And the COVID-19 pandemic made this a very challenging time to try to work with our jail partners when they have so many other healthcare issues and public safety issues that they're trying to address. And so that really highlights the outer context that matters. We've been able to leverage our coalition members and our community partners for some of those interagency collaboration models. And we have been very flexible in trying to adapt an implementation strategy when we find it isn't working. And we have also learned the importance of persistence and patience. Some of our jails were just not able to partner with us at the very beginning of the study. And we have slowly been able to approach them as vaccinations are increasing. So I am going to stop there, and I want to thank you all for your time today. I just wanted to share one more thing, that through our overdose education program, we've been able to partner with about 98 agencies. Not all of these are justice agencies, but we have been able to partner with these 98 agencies and been able to distribute over 25,000 naloxone units, which has made a great impact on our 8 Wave 1 communities. So thank you for your time.
Thank you, Dr. Oser. I really appreciate it. Dr. Taxman, can we turn the presentation, the webinar over to you?
Happy to do so, but I need Carrie to stop sharing. Thank you. Thank you very much. So, thank you. So I really appreciate both Tyler and Carrie's presentation that shows some of the innovations. What I wanted to accomplish today was to begin to help us understand the context by which the JCOIN initiatives, as well as some of the current standing of reentry, is moving away from this recidivism reduction framework and thinking much more of a desistance framework, where the individual is valued and empowering individuals to be able to better manage their lives, whether it's through medication or using peer navigators, or whether it's being involved in different types of services or developing support systems. All of those are designed to really empower individuals. So the presentation that I'm going to give this afternoon basically presents the desistance framework. And then I want to display some of the work that Jessica Halsey and the Addiction Policy Forum have been doing in JCOINs as part of the Coordination and Translation Center to really engage the stakeholders and the community in change practices. So, up front, Dr. Wiley talked about the role that NIDA plays. I can say NIDA's had a great influence on my career, and this presentation actually draws from some recent studies, including the JCOIN Coordination and Translation Center. But what's most important is that much of the work, particularly that is being done within NIDA as part of JCOIN, as well as individual studies that in the field, is really about moving away from a framework of thinking about sort of a frailed individual as a way of trying to help people think about how to change. So this is a classic, we have to reform the system to stop recidivism. 70% of the people who are released from state prisons come back within 3 to 5 years. And the focus of recidivism studies and recidivism reduction efforts is really based on a premise that there will be a single point in time in which a person ceases being involved in crime or offending behavior. And the focus to a large degree, is focusing our attention on the event of which is an arrest or some involvement in the justice system. And there's an emerging lens within the field of criminology and criminal justice, which is a focus on desistance. And the emphasis of desistance is much more about helping individuals change, learning about how to help people change. And that involves new ways of thinking about transforming individuals from thinking of themselves as, I wrote an article once, I called it the outlaw mentality, as compared to, thinking about themselves as really a member of the community and a positive member of the community in terms of having impact as their role of individuals' roles, both in terms of being a parent, being an employee, being a member of some sort of religious organization, contributing to the community good. And so, the focus of DiSilvestro is really changing the lens. So we're much more interested in how do people change and what we can do to actually facilitate those efforts. So there's a big change right now where the emphasis is moving away from the concept of reentry and really trying to focus much more on integration. But I will say that there are some people who basically say that we're not focused on reintegration, we're actually focused on integration, because many people involved in the justice system, as we know, have had difficulties in their lives. And those difficulties have actually interrupted adult development and engagement as a pro-social member of the community. And typically in reentry programs, we're thinking about the structure of programs and services. I provided a map here, which is kind of used as a way of thinking about what type of formal social controls and informal social controls exist, and the mishmash of different organizations and structures and activities and processes that can actually go on. Some colleagues of mine have basically titled this, "The system isn't broken, it's all intentional." And they make, Ortez and Jackie basically make the argument that, the prison reentry process is an industry that's really designed not to lift up the individual, but actually designed to actually keep someone constrained. And I think what we heard from Tyler and Carrie is a different lens, which we're really trying to lift up the individual, give that person support as they walk through life, and help that person develop and access the types of services, whether informal or not, as a way of trying to become, a more productive member of the community. We also know that, there's a lot built into what we've actually done, in our mass incarceration era that has created structural factors that have a big impact on people's ability to be productive. And those have to do with the array of collateral consequences, the difficulties people have in securing housing, employment, all of those structural factors that often get in the way from an individual actually, integrating into mainstream society. We also are very aware that stigma, and we've learned this quite a bit from the addiction treatment field, but we're now learning about how the criminal justice system has an equally role to play in devaluing the individual, but also labeling the individual. And so we're, becoming increasingly aware about language and how we describe people in various medical or justice statuses can actually serve to either empower someone or to actually reduce the person's self-efficacy. We know about these structural hoops that get put in place that make it very difficult for people to navigate. And we also know that oftentimes a lot of the reentry structures that are put in place actually are informed as breaking bonds with someone's support systems. So, this presents us with kind of a challenge. And the reason I wanted to bridge this, have this discussion today, was really to support many of the initiatives that are undertaken under JCOIN and the HEAL initiative, but that actually focus an attention on what's called an identity transformation, or helping the person who's involved in the justice system connect to the community and learn to really manage either their substance use disorders, other chronic health diseases that an individual might have. So, in criminology, this falls under a different framework than recidivism reduction, because recidivism reduction tend to really focus on what programs do people get involved with and whether those programs have an impact. Desistance is really a process that looks at events that unfold over time, about decisions that people make, and how to help people grow and evolve in those decisions. The underlying notion here is that obviously people's decisions are often defined by the social circumstances that they're in, the environments they're in, the rules and regulations and policies and laws that may constrain their ability to grow as an individual. There are different types of desistance. There's maturation theories that have to do with, people will mature out of different types of behaviors and attitudes. But more and more, there's much more of a focus on what's called identity transformations and cognitive transformations. And both identity and cognitive transformations are really helping the individual pursue that productive civic role in a way in which they are able to connect with society and to actually grow and participate in society. So John Lobb and Rob Sampson, early on talked about how life events, having a good relationship with a partner, employment, military service, all of those focus on new ties, and they basically focus on giving people different informal controls to change behavior patterns. They also focus attention on issues related to how culturally defined norms, like being a parent or being an employee or being an active member in your religious community, help to shape behaviors that reinforce pro-social behaviors. And so desistance is really this framework of really trying to help people make these identity transformations. Another perspective is obviously trying to help people develop self-efficacy, but also rethink about who they are and what they can contribute. And that has to do with reconciling one's past, dealing with one's perception of the future, and dealing with one's perception of how they characterize the past that they've actually gone through. So desistance as a framework really tries to really help move along that there's a path of development. So I wanted to just basically feature a couple articles and books that might be useful as one thinks about reframing the narrative here about really trying to boost people up, to help more pro-social development, to help people learn and become more active members of the community. So my dear colleague Shad Maruna wrote a book called Making Good: How Ex-Convicts Reform and Rebuild Their Lives. I think it's a mandatory reading for anyone. It's actually a pretty short book. But what Shad really talks about is, for people to succeed, they really have to think forward about having what he refers to as a redemption script, as a way of putting aside the past that occurs, but really talking about where the person is and what they can actually offer to society. And the condemnation script is really a script that's really about focusing in on everything that happened in the past. In some ways, you could think about this as, the redemption script as being positive psychology, and the condemnation script really being looking and focusing in on past efforts. Peggy Giordano really focuses in on this notion about cognitive transformations, about helping people take hooks that are available to them and transform themselves into something that isn't what their past was. And, you know, asking the question about why staying in the life is not that fulfilling anymore, so they can redefine who they are and what they're actually able to contribute to in society. So the notion here of cognitive transformations, you know, much like Shad's focus on DiSilvestro, is really helping people reframe their experiences, but recharacterize that. And last kind of that I'm going to mention here is actually the work recently of Sean Bushway, who's now at Rand Corporation. And this recent book that he produced actually defines reentry for much more of what he calls a reentry identity transformation. So the focus here is on, you know, his focus here is on really connecting the growth of individuals as a way of trying to transform their identity. And he walks through different developmental psychologist perspectives in terms of how do people adopt a new identity. And that's really the essence of DiSilvestro, is what does this adoption of a new identity look like? So, you know, under the identity transformation, Bushway really focusing, he's a big believer that the concept of reentry is really a misnomer, that it's really an entry issue, that people have to develop attachments, and that, you know, there needs to be a focus on helping to achieve individual agency and foster that human development. So I raise this because as JCOIN, as Tisha mentioned from the beginning, JCOIN's on an adventure to really expand and think about how do we reduce recidivism, but actually help people learn to deal with different types of disorders like opioid use disorders. And so, you know, JCOIN has really focused our attention on valuing the individual. So the mission that JCOIN, and Tisha went over this from the beginning, is really a mission by which the notion is to help the justice system really provide access to effective treatment services, whether the person's in prison or in jail or in the community. And how is this connected to this notion of identity transformation? If you think about, you know, the fact that oftentimes people are exposed to treatment services that are not effective, or they're provided with services that really are mismatched with the substance use disorders or mental health disorders that individuals have, that really just basically serves, you know, to basically put the person into a place in which they can't really make advancements or grow as a human being. And so the vision that, you know, JCOIN has set out is really a vision about trying to really integrate and use the justice system as a service delivery system to fulfill some of the goals of really trying to help people re-identify themselves as a member of the community, but also to, you know, just like other citizens, address some of the needs that individuals have. The way that we are pursuing this goal, at least from the dissemination and diffusion perspective, is really to do outreach and to move research to practice. These webinar series that JCOIN is hosting is designed to share information about what we're learning in research, which Tyler did in terms of the efficacy of different types of medications and different processes, and also share ideas about creative solutions to some of the service deliveries, those structures that don't work well for individuals. And Carrie gave a number of very exciting ideas that they're trying in the Kentucky JCOIN Hub and or the HEAL communities. But, you know, as a mechanism, Jessica in the dissemination and stakeholder core is really outreach to almost 100 organizations as a way of thinking about how to push research out and to really build this notion that people who are involved in the justice system are deserving of effective treatment and prevention services. So one of the things that we've done is, as a team in 2019, the JCOIN Steering Committee adopted and advancing the use of person-first and non-stigmatizing language. Again, part of the effort here is to, dismantle some of the stigma and barriers to care that might occur. And we adopted this as a way, as a JCOIN, as a way of being able to, one, make a statement about how language matters and how important it is for us to respect the individual, but also demonstrate respect for the individuals by the choice of language that we use. So this particular, pamphlet essentially describes the policy of JCOIN, or using person-first language. We're adopting it in a way in which we're thinking about using it not only for addiction disorders, but actually for justice-involved populations. So instead of calling people inmates or offenders, really focusing our attention on the status that the person is in, but not using some of those, more negative language. The other parts that we're soon to release is a document about images and our choice of images, because the choices of pictures that we use, whether it be in a PowerPoint or it be in a pamphlet, has a lot to say about how we value people. And so the non-stigmatizing imagery recommendations pamphlet, it was developed from some focus groups that APF did, will give us guidance on sort of how to use pictures of the system or of treatment services without actually also, undermining individuals or trying to, again, re-stigmatize individuals. This series, this webinar and other webinars are really designed around trying to push out information in the field. We had a really exciting webinar that was done by Dr. Earnshaw and Dr. Howe, and I think it was in February, talking about stigma. And Dr. Howe actually presented information on how the criminal justice system stigmatizes individuals, labels individuals. Again, these are designed to really educate us, and so I provided this link here, and for anyone who registers on the JCOIN website, you would get access to this webinar and a series of other webinars. And then we are developing e-courses that really build upon this framework of effective practices, but effective ways of helping people change. These are just some of our colleagues and some courses that have been done in the past. And essentially the model, the diffusion model that we're using here as a way of supporting, change in the justice system and adoption of more evidence-based treatments has to do with tailoring these presentations to different communities. So we know that prosecutors, we know that judges and defense attorneys and treatment providers and probation officers and jail administrators all think differently. And so, we're developing a core set of courses that are really designed for different populations and audiences. And finally, this is kind of a list of some of the upcoming, e-courses that we're doing with key associations in our field. And the goal, again, of these e-courses is to really push out the research literature, push out, efforts to really help redefine quality services, and again, to facilitate some of that transformation that we're hoping both for justice actors, but also people who are involved in the justice system. So I wanted to take this opportunity to encourage you to sign up for the JCOIN website. I sound like an advertisement here. And also to contact either myself or Jessica with any questions. And I also wanted to take this opportunity to really encourage us to think about DiSilvestro as a different framework by which we can really help people to better achieve quality of life, but also, become more active in the pro-social nature of our communities. So thank you.
Thank you, Faye. Thank you to all of our presenters for such amazing content and overview of research that's so critical to share with our practitioners that are part of this network. If you have questions, we have a few more minutes until we have our wrap time. So if you have questions, please put them into the Q&A box. A couple little announcements for some themes here. We will make the webinar recording available. Please go to JCOIN-CTC.org and sign up for updates from us, and we will make sure we post the full webinar and information there shortly. If you need a certificate of attendance or completion for the course for CEUs, please email me or info@addictionpolicy.org, and we will send you that certificate. You can usually sort of submit that to your accrediting body to get credit for the hour and a half with us today. And if you have other questions specific to any of our presenters that we don't get to today, please feel free to reach out to us, and we will try to get all of your questions answered and send you email responses. We did have one question, since we have a few minutes. It was down here about, I think Dr. Winkelman spoke briefly about sort of increased incidence of stimulant use disorder in addition to opioid use disorder in the jail system and in the patients that you treat. And I know you responded in the chat box, but could you speak briefly to some of the treatments that are available for stimulant use disorder as an update for all of our panelists and participants?
Sure. My first sentence of that response was probably the most accurate, which is it's very challenging. There's a fair amount of evidence for things like contingency management. Those types of treatments can be challenging to implement, particularly in a criminal justice setting. NIDA has funded work looking at a combination of medications to treat methamphetamine use disorder that is very promising. I think that study was released earlier this year in the New England Journal of Medicine. But I would say that we hopefully are at the early stages of better developing more novel treatments. And I think the rise of stimulants has been flying under the radar for the last several years. And I think now clearly has the attention of policymakers and funders, and is a very active area of research. And hopefully we will, in the not too distant future, have some treatments that are as effective as medications for opioid use disorder. What the other thing I would add is that people who use opioids and methamphetamine or cocaine can be treated with medication for opioid use disorder. That medication does not necessarily treat the stimulant use disorder. Anecdotally, I would say that my patients who do well with medication for opioid use disorder often have decreases in their stimulant use as well. And so as most places across the country see rising co-use of stimulants and opioids, it's important to know that you can still use medications for opioid use disorder.
Thank you so much. I have a couple more questions that have come in. A question from Carol. How do we get the jails to allow the use of MAT here in her community, which does not allow Suboxone or methadone? any takers among any of our panelists. So if you have
Well, I would recommend that Carol contact us, because Todd Mulfenter and his team at the University of Wisconsin is actually running a study under JCOIN in which we're working with jails and or community providers to look at the issues about implementation of MOUD. So, that study is still recruiting sites, and it might be a good way for the jails that she was talking about to learn more about MOUD, but also get some technical assistance free as part of the study to look at how they could implement MOUD within their jail environment. So just so people know, we have around 30 sites so far in that study, and we need another 18. Rather ambitious study, but that's a good way, because each of the jails will get assigned a technical assistance coach, and it's going to be using the NIDA text process, which has been found to really improve the delivery of services across many different spectrums. So I'll put my email address, but if you would like to contact me to find out more information, I can send that to Todd's group.
Great, thanks, Faye. We have a few other folks in the chat that are interested in potentially signing up for your study as well.
Excellent.
Great.
That'll make us happy.
and lots of wonderful comments and lots of thank yous from all of our participants. We had a great attendance today, such interesting presentations and important research for us to share widely. For a few little reminders, please sign up at JCOIN-CTC.org for future events, to see a recording of this event, and for more information and resources available from JCOIN. And if you need a certificate of completion or attendance for today, email us at Addiction Policy Forum at info@addictionpolicy.org, and we'll get that over to you right away. Thank you to everyone for taking the time this afternoon. I learned so much, and I'm so grateful to our researchers for taking the time with us, and we'll see you all at our next webinar in the series.